Last week or 2 weeks ago, I discussed with you the evolution and development of the upper limb. We concluded that the upper limb has two fundamental muscle compartments, an evolutionarily and developmentally ventral compartment, evolutionarily and developmentally dorsal compartment, and that the innervation of the limb is determined by which compartment you're in, whether you're a ventral or a dorsal muscle, and certain nerves go to ventral muscles and certain nerves go to dorsal muscles, and you learn that a muscle of the limb is defined as a muscle that derives from the limb bud mesenchyme. But how would you deduce what muscles arise from limb bud mesenchyme? Gentleman who's staring at me. Because you're not interested in muscles that don't derive from limb bud mesenchyme if you're going to talk about the brachial plexus. So what was our clue as to whether a muscle was a true muscle of the limb? Anybody? He doesn't remember. Anybody remember? What? Well, attaches to the limb is so close to a long bone of the limb. So let me ask you, is serratus anterior a muscle of the upper limb? No. Are the rhomboids muscles of the upper limb? No. They are not innervated by the brachial plexus. They are innervated by early branches of ventral rami before those ventral rami go to form the brachial plexus. And of the ones which are innervated by the brachial plexus, if it arises from the scapular ossification element or lies on the back of the arm or the forearm, and there are none in the hand, it's dorsal. If it arises from the coracoid ossification element or lies in the front of the arm, forearm, or in the hand, it's ventral. I won't go through the actual innervations now. A similar pattern will be true of the lower limb as well. And I'm going to show you this video again only because I think it is astoundingly beautiful. You've seen it before, you get a chance to see it again. Take a look at the lower limb this time. We start with our friend, the lobed-finned fish of 380 million years ago, but instead of paying attention to the pectoral fin, we now pay attention to the pelvic fin. It, as its pectoral partner also had, it has a preaxial border, the edge which faces the head, and a postaxial border, the border which faces the tail. If we take a cross-section through the pelvic fin, it looks very similar to the cross-section we took through our pectoral fin, except the girdle bone is not called a pectoral girdle, it's called a pelvic girdle. And it is not comprised of scapular and coracoid elements with a glenoid cavity in the middle for articulation with the long bone, but it has a cavity for articulation with the long bone called the acetabulum, which means little vinegar cup. Acetic acid is what gives vinegar its flavor. And it has a process which extends dorsal to the acetabulum called the iliac process, and a process in this fish which extends ventral to the acetabulum, and that's called the ischiopubic process. There are muscles of this pelvic fin. Some arise from the iliac process, and others just sit from bone to bone on the dorsal aspect of the limb. Some rise from the ischiopubic process and run bone to bone on the ventral aspect of the limb, and these are the fundamental dorsal and ventral muscles of this fin. If we do a cross-section through that pelvic fin, it looks exactly like our cross-section through the pectoral. Dorsal muscle group dorsally, ventral muscle group ventrally. This is the same section, a little bit different than the section I showed you of the human embryo through the cervical 5 through T1 region. That's where the upper limb develops. This is through the L2 through S3 segmental region of the embryo, that's where the lower limb will develop. There's no heart there. That's one of the only differences, really. There's just a gut tube, which will become your intestine. But all the other things are the same. There's a lower limb bud between L2 and S3. I mean, it spans that entire distance. That lower limb bud becomes filled with something, a loose mesodermal tissue called limb bud mesenchyme, which is derived from the lateral plate. And then that limb bud mesenchyme becomes the long bones of the developing lower limb. And in the lateral plate, the mesoderm will become the pectoral girdle. It's not so obvious in fish that there are separate ossification elements, but certainly in human embryos, and we'll see later in evolution, there's a separate ossification element for the dorsal part of the girdle called the iliac ossification element. And there are, surprisingly, 2 separate ossification elements for the ventral part of the girdle. One is called a pubic ossification element, and the other is called an ischial ossification element. And you'll notice I did not say ischial, because that is the wrong way to pronounce it. The right way is ischial. All right? So there's 2 ossification elements. In any particular section, you're only going to get one or the other. That's why I say ischial or pubic ossification element, because I don't know which one I've caught in this diagram. And then hypaxial dermamyotome cells between L2 and S3 migrate into the limb bud, and they will form the striated muscles of your lower limb. And they will organize themselves into a dorsal and a ventral group. And the dorsal ones will either take origin from the iliac ossification element or lie on the dorsal aspect of the limb bud, and the ventral ones will take origin either from the ischial or pubic elements or lie on the ventral aspect of the limb bud. So human embryo recapitulates a little bit, more or less, fish. And then the fish turned into our primitive tetrapod. I should be able to go through this very quickly. I think the whole lecture won't take long. And if we look now at the pelvic limb of our primitive tetrapod, of course it sticks out to the side, and it has its foot down on the ground. It has a preaxial border and a postaxial border, just like the fin did. It now has segments, though, unlike the fin. And the proximal segment of your pelvic limb of a primitive tetrapod is called the thigh. In it is a single bone called the femur. So the thigh is the comparable region to the arm or upper arm, as we know clinicians say. Femur is the comparable bone to the humerus. And that femur articulates with the pelvic girdle at the hip joint, which is obviously the comparable structure to the shoulder joint. In the leg, you'll see I put lower here. I told you that in anatomy, the part between your shoulder and your elbow is called the arm. But the clinicians refer to it as the upper arm so that there are no mistakes and there are no misunderstandings, the word arm being used by the common public to mean the whole upper limb. Similarly, that the word leg is used by the public to mean the whole lower limb. So clinicians, so they don't get confused, refer to this segment as the lower leg, even though in anatomical terms it is the proper name for that segment. Distal to the knee is the leg. And I will tend to use the term lower leg so we don't get confused. There's a preaxial bone, the tibia, that's therefore the lower limb's version of the radius. A postaxial bone, the fibula, therefore the lower limb's version of the ulna. Those are the 2 bones of the forearm, which are preaxial and postaxial. The joint is called the knee. That's the lower limb's version of the elbow, joint between thigh and lower leg. And then there are a bunch of little bones here, distal to the lower leg bones. They were called carpals in the upper limb. In the lower limb, they are called tarsals. The region of the upper limb that carpal bones lay in was called the wrist. Here it's called the ankle. And there are 5 digits, just like there were in the upper limb. And this is called the foot, as opposed to the hand. Or in Latin, this is called pes, as opposed to manus. So everything is the same, really. The preaxial digit of the lower limb is the biggest of the 5 digits, just as was true in the upper limb. But in the upper limb, this is called the pollex. And in the lower limb, this is called the hallux. And then there are, instead of metacarpals in phalanges, there are metatarsals in phalanges. Very easy, very easy. Just memorize the names. When you actually look at this primitive tetrapod, there's a bit of a change from the fish and the embryo that I showed, because I didn't take you far enough in development of the embryo. What you find is that the iliac ossification center has grown and has formed a joint with some of the vertebrae. All right, now these vertebrae will become the sacrum in mammals, and so this will become the sacroiliac joint. So the iliac ossification center forms a true synovial joint with a vertebral column in primitive tetrapods, and it does meet the ischium or pubic centers at the acetabulum, as I said. Here is the simple, basic tetrapod pelvis seen in lateral view. So we see the big iliac ossification center meeting the ischial and pubic ossification centers to form the acetabulum, with a gap between the ischial and pubic centers, which is called the obturator foramen. And this is the way it is in humans. So humans don't look that much different from primitive tetrapod. Big iliac ossification center, portion of the hip bone formed by the ischial center, a portion formed by the pubic center, all three meeting in the acetabulum, and a big gap between the ischium and pubic centers, which is called the obturator foramen, which is covered over almost entirely in life by a connective tissue called the obturator membrane. It's just an extension of the periosteum of the ischium across that hole to join the periosteum of the pubis, and that's called the obturator membrane. There's a tiny little gap at the very top of it, and that gap is for the obturator nerve to get out, an obturator artery to get out. Most of the foramen is occupied by connective tissue. There are dorsal muscles and ventral muscles of our primitive tetrapod. The dorsal muscles arise either from the iliac center, although one or two may actually gain origin from the vertebral column, just like we saw the latissimus dorsi in the upper limb migrated and gained origin from the vertebral column. And then there are ventral muscles arising from the ischium or the pubis, or lying on the ventral aspect of this tetrapod limb. Cross-section looks the same as the upper limb. Now, we went from our tetrapod to our mammal of the upper limb by rotating, bringing the limb under, and then pronating simply so we could walk. There's going to be a similar, in the sense that there will be a rotation and a bringing of the pelvic limb underneath the body, but it differs in two dramatic ways, dramatic to me anyway. This is the upper limb. I will remind you what the upper limb did. As we are looking at it this way, it rotated counterclockwise by 90 degrees. The preaxial border came to face dorsally, the postaxial border came to face ventrally, and then it was brought underneath so that the dorsal muscles faced caudally on the caudal surface of the limb, and the ventral muscles were on the cranial surface of the limb. That was the upper limb. When we look at the lower limb, the rotation is exactly the opposite. It rotates 90 degrees, but as we are looking at it, it rotates 90 degrees clockwise, so that the preaxial border now faces ventrally, and the postaxial border faces dorsally. That's exactly the opposite of the upper limb. And so that's the major difference. Another difference is that some of the dorsal muscles and some of the ventral muscles don't participate in the rotation. If they all did, you would expect the dorsal muscles to be cranial, on the cranial surface of the limb, and the ventral muscles to be on the caudal surface of the limb. But since they don't all do it, you have dorsal muscles on the cranial surface and a second group of dorsal muscles on the postaxial surface of the limb, or region of the limb. And the ventral muscles, yes, you have those which rotate and they end up on the caudal surface of the limb, but those which don't rotate, get stuck in place, they end up on the preaxial surface of the limb. So whereas the upper limb had 2 compartments, the lower limb has 4 compartments. It has a compartment of rotated dorsal and ventral muscles. Obviously, there are 2 compartments. and 2 compartments of non-rotated dorsal and ventral muscles. And then it's brought underneath the limb. And of course, you see one obvious thing is because of the opposite rotation, the knee faces forward, all right, whereas the elbow faces backwards. All right? The foot faces forwards. And you don't need to pronate it to get your toes to face forward. They face that way by virtue of the embryonic and developmental rotation. So you don't have to do that funny little thing that the forelimb had to do. And we can see in this picture 3 groups of muscles. We can see the dorsal group of muscles on the cranial surface of the limb, the ventral group on the caudal surface of the limb, and we see the dorsal muscles on the postaxial side of the limb. We don't see the ventrals on the preaxial side because they're hidden by the blackboard. I'm going to try to do this, but I can't do it so well. But I will show you someone who can. This is now lower limb, all right? The rotation is like that, so that the preaxial border faces ventrally. And then the limb is brought underneath, but you'll notice that I cannot get my elbow forward. Can anybody do that? You don't have to. Because 2 years ago, there was a student who could do it. His name is Raja Pillai. You know Raja. He's an MD PhD student. Right. So he was nice enough to come down, and I don't know how well this is going to project, but we'll see.
Can you get your elbows point forward?
Like that.
Well,
So,
see, what you got to do is first you got to go on.
hold it close.
When this limb has in the position of rotation and underneath, and you have your dorsal muscles here on the cranial surface of the limb, and you have dorsal muscles on what is the lateral or postaxial surface of the limb, and you have ventral muscles on the caudal surface of the limb, and ventral muscles on the preaxial or medial surface of the limb. And when you stand up and you are human, the dorsal muscles are now on the anterior surface and on the lateral surface, and the ventral muscles are on the posterior surface and on the medial surface. And just like the upper limb, the plexus, which innervates the lower limb, will divide into some nerves derived of developmentally dorsal axons that are going to go solely to dorsal muscles, and some nerves derived from developmentally ventral axons going solely to ventral muscles. But we need different nerves for different compartments because there are 4 compartments, and we have to allow for the innervation of all 4 compartments, 2 dorsal and 2 ventral. Now, this thing is the lumbosacral plexus. The good news is tremendously good news for you. You do not have to know the formation of the lumbosacral plexus. And there's a good reason you don't have to know the detailed formation of it and draw it like you do the brachial plexus, because it is buried deep within your pelvis. And its formation is less clinically significant. The brachial plexus is sitting, just in your supraclavicular and armpit region, very susceptible to injuries by trauma, stabbings, bullets, things like that, whereas the buried lumbosacral plexus is much less subject to injury. Maybe even more importantly, the brachial plexus is a focus of what's called regional anesthesia. An anesthesiologist with ultrasound guidance can go and specifically inject one of the trunks or one of the nerves of the brachial plexus to give a regional anesthesia of the upper limb so you can perform a surgery there without general anesthesia if you want, or to control the pain following surgery. There is regional anesthesia of the lower limb, but it's not done at the level of this plexus, which is so buried deeply within the pelvis. It's done after the nerves have exited the pelvis. So you just don't really need to know this detailed formation. What you do need to know in terms of a lumbosacral plexus is that it's really two plexuses, the lumbar plexus and the sacral plexus. Lumbar from L2, 3, 4, sacral from L5, S1, S2, S3, with only one little thing joining them. That little thing, which I hope you saw in dissection, is a small branch of the L4 ventral ramus, which joins the L5 ventral ramus. And when that small branch of L4 joins L5, it forms something called the lumbosacral trunk. I know you saw the lumbosacral trunk in dissection. You may not have seen the branch of L4 that joins L5 to make it, but that's why this is called the lumbosacral trunk, because it's not just L5, it's got a little bit of L4 in it. If it were not for that, there would not be a lumbosacral plexus. There would be a lumbar plexus and a sacral plexus, and they would be completely separate. But because of that small nerve there, you now have something that's called the lumbosacral plexus. But they, in a way, behave as if they were two separate ones anyway, because each plexus has its own dorsal nerves and its own ventral nerves. The lumbar plexus has a giant dorsal nerve called the femoral nerve, and a smaller ventral nerve called the obturator nerve. You've seen these in dissection, I'm certain. The sacral plexus has many more branches than the lumbar plexus. It's got a lot of small dorsal, well, not a lot, but some small dorsal nerves. One is called the superior gluteal nerve, which innervates gluteus medius and gluteus minimus, muscles which arise from the iliac ossification center, hence are clearly dorsal. All right? And it has some branches to the piriformis, which arises from the sacrum. So this is one of these dorsal muscles that has migrated to gain origin from the vertebral column. The sacral plexus also has a dorsal nerve called the inferior gluteal nerve. The inferior gluteal nerve innervates the gluteus maximus muscle. That's all it does. That's a muscle which arises from the sacrum and from the iliac ossification element, so very clearly a dorsal muscle. And that covers all of the dorsal branches, the superior gluteal, inferior gluteal, and piriformis nerves, with the exception of one. And that one is called the common peroneal nerve. All right? And that, therefore, has to do all of the other dorsal muscles innervated by the sacral plexus, other than gluteus medius, minimus. Superior gluteal also does tensor fasciae lata. You'll see that today. Should have said it. Gluteus maximus and piriformis. All the other sacral plexus innervated muscles have to be done by the common peroneal. The sacral plexus has some ventral nerves that are small, nerve to quadratus femoris and inferior gemellus. You don't have to be a genius to figure out what muscles it innervates. It innervates the quadratus femoris and inferior gemellus. Nerve to the obturator internus and superior gemellus, which does what its name implies. And then all of the other ventral muscles innervated by the sacral plexus are done by the big ventral nerve called the tibial nerve. Now, you may not have heard of the tibial nerve and the common peroneal nerves before this lecture, I don't know, but you certainly have heard of the sciatic nerve. The sciatic nerve is a phony nerve. It is just these two nerves bound up in a single connective tissue sheath. It is composed of the common peroneal nerve and the tibial nerve, and in reality doesn't exist other than as an artifice of nomenclature. So, how do these break up to innervate the muscles of the lower limb? Well, we know that in the thigh there are going to be four compartments, a dorsal compartment on the anterior surface and a dorsal compartment on the lateral surface. And there are going to be two ventral compartments, a ventral compartment on the medial surface and a ventral compartment on the back or posterior surface. So these are the four compartments. The lumbar plexus does some of these compartments, and the sacral plexus does some of these compartments. The lumbar plexus does the dorsal compartment on the front of your thigh, and it does it by the femoral nerve. So all the muscles on the front of the thigh, which are dorsal muscles, some of which arise from the iliac ossification center, these are all done by the femoral nerve. The lumbar plexus also does the ventral muscles on the inside or medial surface of your thigh. These are done by the obturator nerve. Ventral muscles arise from either the ischial ossification center or the pubic ossification center if they arise from a portion of the hip bone. These done by the obturator nerve arise from the pubic ossification center. Adductor longus, adductor brevis, a big part of adductor magnus. There is one exception to the rule, that the medial compartment muscles are done by the obturator nerve, and that's a muscle you'll see today called pectineus. I don't know why this is true. Nobody knows why this is true. Pectineus is done by the femoral nerve. It shouldn't be. It arises from the pubis. If you arise from the pubis, you should be done by the obturator nerve. You should be a ventral muscle done by the obturator. It's a muscle which arises from the pubis, is done by the femoral nerve. Interestingly, although I don't know that I've ever seen an accessory obturator nerve, it is constantly described as a separate innervation to the pectineus in some people, something called an accessory obturator nerve, which would be then a ventral nerve. But I don't know that I've ever seen one. I've only seen pectineus done by femoral. So that's just an exception to it. The sacral plexus does the lateral and posterior compartment muscles of the thigh. The lateral compartment muscles are the gluteal muscles. They line the lateral surface of the thigh, arise from the iliac ossification center, and a muscle called the short head of biceps femoris. There's a biceps brachii, you know that, two-headed muscle of the arm. Biceps femoris is a two-headed muscle of the thigh. It's got a long head and a short head, but is really unusual in that the long head is a ventrally derived muscle, and the short head is a dorsally derived muscle. And in fact, most primates do not have a biceps femoris. Most primates have something equivalent to the long head and another muscle called a tenuissimus. The only reason I tell you this is because the tenuissimus can be traced evolutionarily to evolve into the short head of the biceps. The tenuissimus is a muscle which arises from the sacrum. So it's very clearly a dorsal muscle, and you can trace its evolution into the short head of the biceps. So the short head of the biceps is a dorsal muscle that is joined with a ventral muscle to form a two-headed muscle. But the fact that it's dorsal means it's got to be innervated by a dorsal nerve. And since we've already covered inferior gluteal and superior gluteal, the only other dorsal nerve of the entire lower limb is the common peroneal. So the short head of the biceps is done by the common peroneal. And the common peroneal will do every other muscle from here on down, dorsal muscle. And then the sacral plexus innervation of the ventral muscles on the posterior compartment of the thigh is the tibial nerve. Now, easy. Femoral, gluteals, and common peroneal. Obturator, tibial. These muscles on the posterior compartment of the thigh, ventral muscles, arise from the ischial ossification center. Those on the medial compartment arose from the pubic ossification center. These in the posterior compartment arise from the ischial ossification center, done by the tibial. Higher segments of a plexus tend to do their innervation near the proximal part of the limb. Lower segments of a plexus tend to innervate muscles more distally. You saw this in the upper limb. I hope you noticed that the hand is done entirely by C8 and T1. Shoulders mainly 5-6. Higher, more superior segments of a plexus do the more proximal muscles. Lower segments of a plexus do the more distal muscles. Well, the lumbar plexus is the higher part of the lumbosacral plexus. It's L2, 3, 4. It is concerned mainly with proximal muscles, front of thigh, inside of thigh. It does not go below the knee. Everything below the knee is done by the sacral plexus, which is the lower part of the lumbosacral plexus. So we don't even have to ask what the femoral and obturator nerves do below the knee, because they don't do anything. The lumbar plexus doesn't go below the knee. Furthermore, the medial compartment doesn't go below the knee. So there wouldn't be anything for the obturator nerve to do anyway. There are no medial compartment muscles below the knee. That compartment is lost. How do you know that compartment is lost? Because you can feel your tibia. If you had muscles there, you wouldn't be able to feel your tibia. But you can. It's a subcutaneous bone, and that's because the medial compartment muscles have been lost below the knee. So We know that femoral doesn't go below the knee. We know that obturator doesn't go below the knee. And we know the medial compartment's gone below the knee. So what is left here, really? Common peroneal and tibial are the only things left to do anything down here. And that's what they do. Now, the common peroneal breaks up into two branches at the knee. One's called the deep peroneal, and it does the anterior compartment. It does for the lower leg what the femoral did for the thigh. The anterior compartment muscles of the lower leg. The other branch of the common peroneal is the superficial peroneal, and it does what the gluteal nerves and the isolated branch to biceps femoris from the common peroneal did in the thigh. The superficial peroneal does the lateral compartment muscles of the lower leg. Two dorsal compartments, developmentally dorsal, done by both by the common peroneal through its deep peroneal branch and superficial peroneal branch. There is only one ventral nerve left. We've gotten rid of obturator, got rid of all the nerve to quadratus femoris, nerve to obturator internus. There's only one ventral nerve left, and that's the tibial nerve. And it did the ones on the back of the thigh, and it does the muscles on the back of the calf as well, because all the calf muscles are tibial. And then when we go down to the foot, we lose the lateral compartment, the compartment done by the superficial peroneal. So there are only two compartments in the foot, one which is on the dorsum of the foot, that's the extension of the anterior compartment, and one on the sole of the foot, which is the extension of the posterior compartment. And the nerves that did the anterior compartment in the lower leg and the posterior compartment in the lower leg are the same ones as do these in the foot, with deep peroneal doing the equivalent, the anterior compartment muscles, and tibial doing all of the other muscles of the foot. You know that there was no dorsal muscle group in the hand, but there is in the foot. There is a muscle which lies on the dorsal aspect of your metatarsal bones, and that muscle is done by the deep peroneal nerve. If you have as an anomaly a muscle on the back of your metacarpals, that will be done by the radial nerve. But you usually don't have that, but this always exists, and therefore the radial nerve equivalent, so to speak, continues into the foot and does a muscle there. All the others are done by tibial. So, you know, essentially it's femoral, obturator, common peroneal, deep peroneal, superficial peroneal, tibial, tibial, tibial on the sole of the foot, and deep peroneal there.
I will also point out in the moment that there are some muscles which are of mixed development and origin. For example, in humans there's a muscle called adductor magnus. Adductor magnus, you will see it today. It has two components. There's the part that arises from the pubis, that's called the pubofemoral part, runs from the pubis to the femur. It also has a part that arises from the ischium and goes to the medial condyle of the femur, and that's called the ischiocondyle part. These are completely separate muscles in most non-human primates. In humans, they join together to form a big muscle we call adductor magnus. By and large, a muscle arising from the pubis is done by obturator. Now, these are both ventral division things. Because if a muscle arises from the pubis, the receptor technique is a ventral division muscle. If a muscle arises from the ischium, is a ventral division muscle. And the part of adductor magnus which arises from the ischium is a ventral division muscle of the posterior compartment. And that portion of adductor magnus is done by the tibial portion of sciatica. So it's a muscle with two ventral division muscles. The pubofemoral part of adductor magnus and the ischiocondylar part fuse, and the muscle gets dual innervation because of that. The part which arises from the pubis from the obturator, the part which arises from the ischium from the tibial. And then in humans, maybe 400 primates that I know of, we have a biceps femoris.